All right, so good morning, everyone. Thanks for joining us. We're going to be doing our health literacy training this morning, and we'll do some introductions. But to begin, I'm going to share my screen. And you guys let me know when you can see the screen. Thumbs up? Okay, great.
We can see it.
Okay, so this is the Wayne County Health Catalyst for COVID Care, Community Access, Response, and Equity. This grant was awarded by HHS to the Wayne County Health Department to improve health literacy, specifically around the COVID vaccine, but in general. So to begin, what we're going to do is I'll stay off, we'll go off camera for a few minutes. And if you're joining us online, please go ahead and you can go ahead and click this QR code, or for you guys in the audience, please go ahead and click that QR code, or Maya has put the link in the chat box. We'd love if you could participate in the pre and post session evaluation. So what I'll do is pause for a few minutes and then resume. Okay, great. Thank you. All right. So we'll go ahead and get started. I'm Dr. Carolyn Custer. I'm the person responsible for the health literacy training portion of this project. I don't have any disclosures, conflicts to disclose, so I'll let Maya introduce herself.
Hello and good morning. My name is Maya Campbell. I'm with the Michigan Community Health Worker Alliance, and I'm a proud community health worker. So welcome, everyone. Thank you for attending.
Okay, so our agenda for today, overview of health literacy. We're going to review 5 health literacy interventions. We'll take a short break, probably 5 minutes. And when we come back, we'll talk about a few strategies to overcome vaccine hesitancy. And if we have time, we'll do a case. At the end of this training session, we expect that you can describe health literacy as a determinant of health and identify strategies to address health literacy. We'll talk about CLAS, which is culturally and linguistically appropriate services, as well as strategies for culturally competent care. And then we'll talk about vaccine hesitancy and some strategies to mitigate that. All right, so we're going to start with this slide. Who has seen this slide before? Just raise your hand. Okay. All right, so we can't talk about health literacy without talking about health equity. Okay, so health equity, we're going to just do a quick introduction. You know, this is the traditional picture that a lot of people have seen, where we have equality on the left and equity on the right. And you can see with equality, everyone's getting the same everyone's getting the same box. I couldn't remember the word. I'm so sorry. But you can see that this doesn't really help out for the little dude over here, and this guy's struggling. So equity really is looking at, you know, you get what you need to succeed, right, to be healthy. But we're going to take it one step further, and we're going to talk about justice. So, you know, equity is good, but justice is even better. You know, we talk a lot about social justice, and what we're talking about is removing the inequities that exist in the first place, right? So that we don't have to have a discussion anymore about equality or equity. We will always have the discussion, but we're working towards justice. Social determinants of health. A lot of you have, you know, worked with social determinants or are community health workers. These are the things that impact health that we don't necessarily treat in the office, right, or in the clinic. These are the things that impact health: where you live, where you work, where you play. You know, the environment that you live in really can impact your health situation. So we need to think about all of these factors, and health literacy is just one part of that. So I'll turn it over to Maya.
Thank you so much. So health disparities. What are health disparities? So the CDC defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunity to achieve optimal health that are experienced by a socially disadvantaged population. And these health disparities do exist because of health inequities and factors like social determinants of health and systems designed with structural racism. All right, so health literacy and Wayne County. I'm sorry, I don't know if we mentioned this, but this is a little bit of an interactive training. So a few times during the training, we'll ask you to come off mute and just share. So if does anyone want to come off mute and just say like what their definition of health literacy is? Just a sentence or two.
What does health literacy mean to you?
Yes. Well, we know what literacy is, right? So, or we'll come back to this in another slide. So maybe we'll give our participants just a few minutes to think about that if you'd like. So health literacy in Wayne County. So there's systems built with structural racism. And of course, I'm sure everyone, if you're not, the term redlining, what redlining is communities that were historically cut off from resources, such as access to healthcare and education.
Sorry.
It's okay. All right, so what does health literacy mean? I know I just asked that on the last slide, but does anyone want to come off mute and just give their definition of what health literacy is? So we know what health is and we know what literacy is. So what is health literacy?
Tim, I saw you come off mute.
Yeah, the ability to understand medical terminology and issues related to your health.
Yes, absolutely. So thank you for that. The next bullet point, Dr. Custer, do you want to talk about Healthy People 2030?
Sure. So, every 10 years we have a strategic plan for the health of our nation. And traditionally, this first definition, was one of the goals, personal health literacy. So we were aiming to improve the ability to find, understand, and use health information in people. But one thing that was added into Healthy People 2030, and part of the whole point of what we're doing now, I'm telling you what, is organizational health literacy, right? So it's the degree that we, as providers or community health workers, equitably enable individuals to find the information. So we're going to talk a lot about what that looks like.
Absolutely, thank you. So health literacy components. So these are the skills and knowledge needed to interpret health information. So the literacy, which is reading, writing, basic math, speech, and comprehension skills. The numeracy, that's the understanding of how math works in the real world. So the factors that impact health literacy, the complexity of the health information. Is it difficult for the patient or the client to understand? Language, is there a language barrier? Age, the state of the patient or client's health at the time of the appointment. Are they sick? Are they anxious? Cultural background as well. And the way the information is communicated by the provider. These are all factors that impact health literacy. All right, so this is just a graphic of that last slide. So there's the individual factors, of course, that impact the health literacy, like literacy skill, health knowledge, demographic, culture, and experience. And then on the right side of this slide are the system or professional factors. So the public health practice, public health infrastructure, and public health workforce. So all these things combined make up health literacy.
Okay, so what are the impacts of low or limited health literacy? On the individual level, persons with limited health literacy are less likely to use preventative health services, like pap smears, mammograms, screenings for cancer, etc. Less likely to effectively manage chronic disease, right? You have to have some basic knowledge to manage chronic disease. More likely to have poor medication adherence, higher rates of hospitalization, ER services versus primary care, higher mortality rates. This is a huge one that we're going to talk about throughout this session, reporting a sense of shame about their health literacy. So we'll talk about some red flags and more to come on that. And all of these things are associated with a higher healthcare cost and expenditure, which, as we know, in this country, we have a huge amount of expenditure. And, by empowering our members, our patients to improve their health literacy, we can actually cut down on those costs. So on a community level, we do really good, I think, in Detroit as far as having opportunities. But if you have a limited health literacy on a community level, those could be missed. lack of preparation for emergencies like severe weather, evacuations, contaminated water, food safety. So these are just some of the more widespread impacts that having a limited community health literacy can result in. So we talked about literacy and health literacy. Right now, we know the average reading level of adults in the United States is 8th to 9th grade. Now, why is this a problem? Most health education materials are written at a 10th grade level or higher. So our materials are more complex than our average, reading level. They do recommend the best reading level is 5th to 6th grade. And there is a way, if you use Word, you can do a spell check or reference check, and it will tell you what the reading level is for that document. Red flags. So if you have a member that in your practice, and some of these behaviors become more apparent, more frequent, they could be an indication that the member has low literacy. So frequently missing appointments, incomplete registration forms if there's a writing issue, non-compliance with medication, etc., asking fewer questions. This kind of goes along with reporting a sense of shame about their literacy or health literacy level. You may find that people with limited literacy are more likely to just kind of nod, right, as you're talking to them. And then at the end, do you have any questions? No. So if that's happening, be aware that that could be a red flag behavior. And we'll have an example of that later. So the meat and potatoes of this is the whole point, using a universal precautions approach. So the material for this comes from the AHRQ Universal Precautions Toolkit. There are links at the end of this presentation to everything that we refer to. So that toolkit's there too. So I know Danita Johnson knows about bloodborne pathogens in medicine. She's a great nurse. So remember when HIV and bloodborne pathogens in general, you can't tell if someone has HIV or hepatitis or whatnot just by looking at them, right? So we decide to do universal precautions, which means anything that's blood or body fluids, we take precautions. We put gloves on. We don't, put it on our bare hands. We wash our hands, etc. In the same way, you can't assume what a person's level of health literacy is just based on what they look like or their education or their job even. So this approach assumes that everyone has difficulty comprehending, and it forces us to learn how to communicate in a way that anyone can understand. And if you get used to this, then you'll be talking to your members in this great, we'll go into that. So the goals are to simplify communication, confirm comprehension, of course, reducing the risk of miscommunication. We need to make our system a little easier to navigate. We know how difficult and complex it is already, and really support patients' efforts to improve their health. So the more we normalize, the less we stigmatize. Any questions so far? Okay. I'm not going to go through all of these spokes on this wheel, but this is what a health literate organization looks like. So the point is, it starts from the top. The leadership's prioritizing it. It's considered in every system process. It takes into consideration the members, so we have 4 words for patients. We call them patients, clients, consumers, and members. So Maya and I will interchangeably use that, but involving members in the processes and making sure that they have buy-in, or you have their buy-in. So this is what it looks like. And I'm going to turn it back over to Maya.
Thank you. So this is another point in the training where I'd ask you if anyone would like to share, to come off mute and share an experience. Would anyone like to share a time when having low health literacy impacted you or a loved one's ability to be healthy?
The examples of family members, maybe, or even yourself at some point.
I'll share. My mom had to have a heart procedure, and what she thought when they said, okay, you have to have a heart procedure because it was located in the surgical department, she just assumed that they were going to open up her chest. She did not understand what, minimally invasive was. So after I explained it to her, she agreed to have the procedure.
It's a great example. Thanks for sharing that.
Absolutely, a really good example. And we'll get a little bit deeper into that, some of those topics or points that you touched on, Danita, as we move through the training. But thank you so much for sharing that.
Maya, can I share really quickly?
Absolutely.
So my father is 86. And he has COPD, and as he's getting a little older, he's having a lot more difficulty breathing, and he has been a little reluctant to use the oxygen. And so he finally had to accept that he couldn't walk from the bedroom to the kitchen, and he really needed the oxygen. So he has having to see the cardiologist more frequently, and he complains about what I'll call the bedside manner of the cardiologist. And so he is not limited in being able to understand, but I think that there is a bit of shame there because the doctor is going really fast. And I think the doctor assumes that he's appropriately communicating, but it's hard for my father to receive the information because he doesn't feel like the doctor is really very concerned. He's rushing. And so I think that that may play that role again in how people are able to process and follow through. Because when he comes from the doctor, we'll ask him, well, what did the doctor say? And he'll say, I don't know, ask your mother. Because he's almost tuned off in a way that he hasn't really processed what has happened in that visit. And so I think with the literacy, being able to understand that people may just need, a bit of empathy, if you will, when they're trying to process, especially a person of his age, just trying to process what I need to do to be successful when I leave here, because he still needs to have the oxygen at the appropriate level to be able to turn it up when he needs to, when he's having trouble. And I think sometimes those instructions, the verbal ones, get lost. He can follow through if he reads, but if you ask him to say, what did the doctor say? He has a lot of difficulty with that.
Well, thank you so much, Wendy, for sharing that example. And we will dive into that more as we move through the training as well. But both Danita and Wendy, you bring up some very, very key points that we'll dive a little bit further into. So thank you. All right. So health literacy interventions. So these are evidence-based interventions and strategies that are used to increase the patient's health literacy and to help create a more health literate environment. All right, so health literacy strategy number 1, clear communication. So Wendy, I know you touched on this a little bit, so we'll dive a little bit deeper into this. So clear communication. So are patients being greeted warmly when they walk into the doctor's office? As a provider or even the community health worker, are we using the patient's words, showing graphics? I'm very much a visual learner, so graphics are super, super impactful to me. Making eye contact, slowing down, demonstrating how something is done. I did love when I worked in a clinical setting when providers or nurses would demonstrate how to use the diabetes testing equipment. That's very powerful. Listening carefully to what the patient or client or member is saying. Limit and repeat content. Invite patient participation using plain non-medical language. I know sometimes we get into autopilot and we assume that people know, that our patients know some what we may find as basic medical terminology, but everyone is not in the medical field, so everyone is not versed in that language. So being specific and concrete and encouraging the patient to ask questions. All right, so 7 things to consider when communicating about health. So the first thing is trust. Will the person trust the information that's being communicated? And who is the best source to put that information out? If we think back to Wendy's example that she just gave, is the provider the best person to give that information? Is there a community health worker in that office that can communicate that? The information itself is the second point. What information is necessary and how will people find it? How much is too much? Information overload is definitely a thing. When we are getting too much information, our brains go again into that autopilot and nothing sticks. So 3, what is the motivation, or how relevant is the information that how relevant is that information to the person we're trying to reach? I'm sorry, Dr. Custer. I always take over this slide. Do you want me to keep going?
Oh, and that's fine.
Okay, so number 4 is the environment. What are the conditions that surround and affect the audience? And 5, the capacity. What is the person's ability to act on the information? Are they facing any barriers? 6 is perception. What will the audience think about the information, and what will inspire them to act on that health information? And the final point, number 7, is the response. How will the patient or how will the member respond? What can you say or do to engage them in their treatment? Thank you.
Okay,
Okay.
so using plain language, we go through this a lot, but of course, like Maya just said, avoiding the medical jargon and using as plain language as possible. So here's some examples of words instead of hypertension, of course, use high blood pressure. The one that I typically point out is diet, because if you ask someone, what is your diet? They may think, are you talking about Weight Watchers or Adkins or, diet, right? But if you say, but what we really want to know is, what do you eat? So what do you eat for breakfast, right? Not what is your diet? Just things to consider about making sure that you're speaking as plain and clear as possible. Your COVID test is positive. So this is an example from, I don't know, Danita, if you were there. She's anyway. So we had you can't be on the call for this one. So we were doing screening or whatever, and and this might be a little different than what actually happened to Danita, because I don't remember, but your COVID test is positive. Someone said, oh, that's good, right? Because positive is a good thing. And in general, positive is a great thing, right? But it can be confusing, right? So we just started writing your COVID, you have COVID or you do not have COVID. And that's okay. We figured out and we adapted, we made it more clear. No, Danita. All right, so that's some of the communication stuff. It really is important to try to use that plain language, communicate at the members level, use their own words even. Maya does an excellent job at this. So we're going to move on to the second strategy. So strategy 1 was communication. 2 is effective health education materials. So this is kind of a fun part. This is going to be a little interactive, so everyone get ready. So we talked about materials are easy to read and understand, right? Check the readability, aim for 5th to 6th grade. The purpose of the material is clear, right? Avoid irrelevant or too much information. Using plain language, we just talked about that. Breaking up material up into chunks that make it easier to understand. So, if someone sees just words all the way down, they're probably turned off already. Making sure that material is broken up. To be effective, it really should identify at least one action item. Visual aids are used effectively, and be aware of confusing numbers. So this is the fun part. We're going to look at some health education materials together, and it's your turn to evaluate. So we're going to start with 3 flyers around vaccination of children for COVID. The one on the left is MDHHS. The one on the right is CDC, and the one in the middle is Authority Health. So when you look at these 3 flyers and think about visual aids, clear messaging, effectiveness in general, which one do you think works best for you?
The one in the middle.
Okay. So keep your cub safe with this cute bear. We all understand that as parents, right? Okay. There's a phone number. It's clear, right? Keep the school year fun going. What do people think about this one? It's not as effective, right?
Yes.
Right.
Hard to know when I can get the vaccine.
Right. And the one on the right is the CDC. And the same thing, right? We have small font. Those are some things. People are turned off to small font. The picture's great. But the message is maybe not as direct as it could be, right? Okay. This one came out, MDHHS put it out, and they put it out in every language possible, which I thought was kind of interesting. So scientists have taken hundreds of steps developed by, decades of research, clinical development, scientists, give our lives back, et cetera, et cetera. Would this work with the population that you serve? Would this move them to get vaccinated? In this picture, what is this picture?
Nope.
And why not, Tim?
Well, I mean, it's, looking back, I mean, there's no call to action, there's, looking at all of that stuff, but also it's very, academic.
Absolutely. It's a great way to put it. So it might work for one of us, but maybe not the population we serve.
And it is a lot to read, too much to read.
This is too much. Wait till you see the next one, Wendy. I'm just kidding. Okay, so the next three are all MDHHS. We're going to start with this one. I bring these first two out because we talk about public health messaging and clear messaging, right? In this particular one that came out, we have two different types of asterisks, and we have small print under the asterisks. So this message becomes confusing, right? Because if you don't know what the Omicron bivalent, monovalent, the small print means, you might be lost. Does everyone see that? The next one, I feel like I got so many calls from people, even one of my friends, she's like, my daughter has COVID, it's day 6, she's febrile, she has a fever and coughing, and her boss wants her to come back to work today with a mask on. I said, no. So this was another one with multiple asterisks, small font in the bottom, maybe not as clear. And, this no symptom or symptom have improved piece. I think a lot of people just maybe didn't read that part. So again, this was kind of a more confusing one. What do you think about this one? Make a COVID-19 plan. So they have these big kind of, and then they have all these little things.
Very too many words.
Yeah.
I don't know where to look.
Right?
And
So-
too small. If you're like me, you need your readers. It's just too much. It's too small.
Yeah. Yeah. What do you think if they just put the big points and maybe the little icons? Yeah. So as far as a general public health message, we could maybe just take all the little font out and just maybe one link to a website at the bottom or something, right? All right, I'm going to turn it over to Maya to look at the next two, the last two.
Yeah. Okay, so this flyer is from MDHHS. So when you see this flyer, taking into consideration our population served, what are your feelings about this? So if you are a parent sitting in a doctor's office with your child, and this is a material hanging on the wall, how do we feel? There's a person in a hospital bed, there's a cute little baby, she's in distress. How does this flyer make us feel? What are our initial thoughts?
They can feel overwhelmed.
Absolutely. It's overwhelming. There's so many words on this flyer. And they're really small. I like the bullet points, but then there's some technical stuff in there that I may not know what's going on here, what these words even mean. Yeah, Donald in the chat mentioned afraid. Yeah, it's complicated looking.
Yes.
Absolutely.
Okay.
But even when you think about COVID itself, it's scary. And so you have a picture of, a child with an IV, and it's just scary.
Absolutely. Absolutely. Thank you for that. Thank you all for your thoughts. So we'll go to the next flyer. So this flyer is from the CDC. So how do we feel about this one? There's no kids in the hospital bed. There's some cute little cartoon graphics. I love this little girl with the puff that kind of looks like me. But I'm thinking about the population served. How would we feel about this flyer? Same scenario. We're in the doctor's office, pediatrician's office with our child. And this is the information about COVID-19 vaccines that's hanging on the wall. How do we feel?
Too much work.
Too much work. Yeah. I like the bullet points again on this flyer, but there's so much information here. So I do just want to mention this flyer and the last flyer from MDHHS, they have the same information.
All right.
So when using health information or health materials, don't assume that your patient can read the materials. When reviewing a handout, because as a community health worker, sometimes what we have in our toolkit is just what we have in our toolkit. We don't have the ability to recreate the wheel. So circling and highlighting the most important information is helpful, and personalizing it by adding the patient's name or their medication, and using teachback to confirm that they're understanding. We will talk more about teachback in a few more slides. Emphasize the importance of keeping the material so that patients can refer back to it, and make sure the patient has internet access before recommending digital materials. Thank you. Oh, I'm sorry. And obtain the patient's feedback on those materials. That does help us improve.
All right, so we've talked about communication and effective health material. We're going to talk about teachback. We're starting to go into the portion of the training where I start encouraging people to follow up on topics that they are interested in. Teachback itself is something that you could learn and practice. It doesn't just happen. You have to kind of work at it. So I'd encourage people to follow up if they don't know about this so they can learn more. So why are we even doing this? So studies have shown 40 to 80% of medical information patients are told is forgotten immediately, and nearly half of what's remembered is incorrect. So we'll talk about teachback. Does anyone want to come off mute or raise your hand if you learned about teachback? Okay. So it's a way of checking understanding, right? So something the cardiologist might have done a little bit better. Basically, we want to teach our patients what they need to do after they leave to take care of themselves, right? To have health. So this is a way of asking them to explain back in their own words to make sure that they know. It's a check and balance. So it's not a test or a quiz, and we never want our members to feel that way, right? This is just clearly, the onus is on us to make sure that we're explaining it clearly. It is important because it's been shown to increase patient understanding, adherence, decrease callbacks and canceled appointments, and improve satisfaction and outcomes. So just a few elements of using teachback. These are kind of the same things that we reviewed with communication, right? So using a caring tone of voice and attitude, having empathy, making sure that your body language and eye contact are comfortable for the person you're with, reader-friendly materials. So then just asking the patient to explain back using their own words, and, again, that the responsibility is on us. So this is just a quick graphic to kind of show, chunk and teach information. So if your member's there and they have COPD and diabetes and hypertension, let's say, you wouldn't want to try to teach all three at once, right? You're going to do COPD first, and then you're going to move on to diabetes. So chunking the information, asking them then, after you tell them the information, to teach back in their own words, allow to consult the material if you have any, that would be good. If they teach it back correctly, then they've got it. You can move on to the next part of the information or process. If they don't teach back, you can reteach using different words, and you just kind of modify your approach until they have a basic understanding, right? So Maya and I are going to do a teach back example. This next 3 slides are representative of a handout. So just pretend like you're looking at a handout with Maya and I. Okay. All right. All right. So Mrs. Campbell, as you know, your COPD and diabetes put you at higher risk for developing severe COVID-19. I'm going to prescribe you the antiviral medication called Paxlovid. This is what a dose of Paxlovid looks like. There's 2 pink pills and 1 white pill in each packet. You need to take the whole packet 2 times a day for 5 days. Here's some additional information about taking Paxlovid. I've highlighted the most important things, such as taking the pills whole. And here's a list of medications that you should avoid when you're taking Paxlovid. Are you currently taking any of these medications, Ms. Campbell?
Yes, I take St. John's wort daily.
Okay, then we'll make sure that you avoid taking that while you're taking the Paxlovid. And here's some side effects to look out for. The most important thing is liver damage. Please call our office if you have any yellowing of your skin or eyes, dark colored urine, or very itchy skin. And here's some common side effects. I've circled those. You can expect those to resolve within 5 to 7 days. Okay, so Ms. Campbell, I'd like to make sure I explained everything clearly to you. Can you please tell me how you're going to take Paxlovid and what you're going to look for?
Yeah, okay. So each pill packet has 3 pills. I need to take 1 packet twice a day for 5 days. Avoid taking my St. John's wort while I'm on this medication. And I can't quite remember what side effects to look out for.
Liver damage is the big thing.
Okay, yeah, that's right. I'll give you a call if I notice my eyes or my skin turning yellow, or I'm sorry, my skin or my eyes turning yellow, or if I get real itchy or dark urine. I'll be sure to give you a call, doctor.
Okay, so that was our very basic example of teach back. Does anyone have any questions? Okay, we're rocking and rolling. So health literacy strategy 4 is not really an evidence-based intervention. It's more of our personal journey in health literacy world. So when I was at Authority Health, I was overseeing all of the resident research and quality and whatnot projects. So we ended up doing a project at a laundromat at 7 Mile in Van Dyke, and the point was to improve health literacy. And our residents went in every Saturday for 2 hours, and we taught about health. And it was a really good experience because at least they learned better communication skills, how to use props, teaching by demonstration. We learned that that's a very valuable thing. And that ended with COVID. But the next step of the project that we attempted to do with them was the Small Steps to Health. And this was to take place in Narden Park. And so the whole point of Small Steps to Health is really the small step behavior change. So those of you who haven't heard this before, it can be really overwhelming when you give someone a really large goal. Like, for example, we know our patients that have obesity need or should be increasing their activity, right? But if you tell them, I need you to do 150 minutes of activity a week, the chance of them actually doing it is probably pretty small because that's so overwhelming, right? But if you say to them, okay, what's one thing you can do to increase your activity? And maybe it's, I had a grandma tell me one time, watching a YouTube video and dancing in the kitchen with my grandkid, that's activity. That's something small, attainable that she was able to do. So when you set goals, you're talking about behavior change. It really is important to think about what you could offer as a small step. Maya, of course, I'm going to turn it to you and ask you to share what your small step behavior change was.
Yes, thank you. So I've been on a weight loss journey. So through my journey, I also set small goals. I love Law and Order. So my treat to myself in the evenings when I get off work, I'd come home, just kind of debrief and relax and watch an episode of Law and Order. So instead of sitting on the couch and watching Law and Order, what I would do, I would walk in place for that 1 hour episode. That was 60 minutes of continuous movement. So I knew every day, in order to watch my favorite show, again, Law and Order, I have to walk in place for that 60 minutes. It was really kind of goofy, but it's 60 minutes of continuous movement where ordinarily I would just be laying on the couch. So it's a small thing, but it did add up to a big change.
Thanks, Maya, for sharing that. All right, so we're going to move on to our final health literacy strategy, and I'll turn it back over to Maya.
Yeah, so health literacy strategy number 5 is considering language and culture. So fortunately for us, or those who live and work in Wayne County, it is a very diverse mixing pot. So it's important to know and understand the population that we serve. So we're going to review CLAS, or CLAS. So what is CLAS? So CLAS standards are culturally and linguistically appropriate services And this is the framework to deliver healthcare services. It's a respectful and responsive to patients' cultural beliefs and preferences and communication needs. And it does promote a health equity and reduce disparities. All right, so the class themes, the principal standard, governance and leadership, communication and language, engagement and improvement and accountability. All right, so strategies to implement in class. So these are language-related strategies. Access language preferences and language assistance needs, use acceptable language services and do not use unacceptable services. We'll talk more about that in the next slide. Plan for interpreter services in advance. When I worked in a clinical setting as a CHW, what I would do, I would look ahead in the schedule. So I'd look ahead for the week and plan ahead. So if I knew that a patient that was coming in Wednesday at 11 needed interpreter services, I would make sure that I had those queued up for that patient. That is also part of the rapport building, just taking it a step further to help build that relationship with that patient. And provide written materials in the patient's preferred languages. So some culturally related strategies: respectfully ask the patient about their health beliefs and customs, avoid stereotyping based on religious or cultural background, and acknowledge and address our own implicit bias. Great. So language translation services, do's and don'ts. So we do want to use bilingual clinicians or staff members whose proficiency has been confirmed. We want to use staff who are trained as interpreters, on-site medical interpreters, or telephone or video interpreter services. We do not want to use clinicians or staff whose training or certification who are not certified as medical interpreters. This is a big one as well. We do not want to use the patient's family members or friends. This is a huge thing. It does pose a problem with the patient's privacy. We want to make sure that we're following HIPAA and respecting the person's privacy and respect their choice to have a quality interpreter present as well. Another big thing is minors. Minors should never be used as interpreters.
Okay, so University of Michigan Care Guides, there's a link in the slide. If you haven't looked at it before, I do recommend just taking a look. They did a really good job in reviewing and creating materials for almost every health condition at the 5th to 6th grade level. So they've either gathered it together or they created it themselves. And they also have multiple languages. So if you are looking for something specific, this could be a useful resource. I love that they have colonoscopy prep in French. I don't know. They have everything. These are some COVID vaccine posters that were made by MDHHS in various languages. So these are also still available if you're interested in using them. So we're going to turn to cultural competence. And I just want to preface this by saying, some of the stuff we're going to cover over the next few slides are things that I said before, like teach back, that you could spend a whole semester on studying, right? So we'll go through this, but I would like anyone with interest to kind of follow up and dig deeper. So we know that religion, culture, beliefs, and ethnic customs influence how we understand health and how we take care of our health. So we really we have to be culturally competent as providers. And this relies on the principles that we've talked about: trust, respect for diversity, equity, fairness, social justice. When we consider culture, we can make better engagement with our patients, better rapport, and a patient-centered treatment plan consistent with their values. So we're going to briefly review how culture can impact health engagement. And I encourage, based on your own population, to do further research and investigation if needed. So let's get started. Health beliefs. Some cultures, people believe talking about an outcome might cause it to occur. So it could be, people could be reluctant to discuss certain health issues. Health customs. In some cultures, family members play a large role in the healthcare decision-making, perhaps an elder or a spouse. Ethnic customs. Roles of women and men may determine who makes the decisions. Religious beliefs. Some religious faith and spiritual beliefs may affect how someone uses the healthcare system or willingness to accept, specific treatment. Dietary customs, this is something we have to consider when we prescribe the DASH diet to everyone, right? It's a great diet, but if you don't know how to cook certain foods, you're going to be at a loss. So when prescribing food or diets, taking into account, does the person in front of you know how to cook that kind of stuff? Or, do they need more resources? Or are there ways that you can adjust their own diet, really getting into it, figuring out what foods they already are eating that are healthier, right? Options. And interpersonal customs. Some cultures, eye contact is appropriate, some it's not, right? Same for physical touch. So really getting to know the population you serve, the persons you serve, and taking all of these things into consideration and making sure that you're doing a person-centered treatment. So part of it is addressing implicit bias. We're not going to go into implicit bias right now, but we all grow up in our own, situations. We all have different families. We went to different kind of schools, etc. So we have our own worldview. We grow up and we develop a worldview, and that's fine, right? Our job is really to make sure that what we've grown up to learn isn't a bias that comes out when we're providing care, right? So looking at our own biases and making sure that they don't impact our ability to be empathetic. Trauma-informed service. Who has heard of toxic stress? I think probably everyone, yeah. Okay. How about adverse childhood experiences? Who's read this book, The Body Keeps the Score? Oh. Thanks, Lucille. Okay, sorry. This book it's deep, but I encourage everyone to read it. We understand how trauma and toxic stress impacts the body. We know in childhood, adverse experiences can impact development, right? Which leads to long-term outcomes. So I bring this up to say, we're going to go through this a little bit more, but just to understand that culture, population, etc., everyone has trauma. It's pervasive, and we need to recognize it. And we need to understand that it does cause impact to our health. Maslow's hierarchy of needs, another topic that we could spend a semester on, but really understanding that for a person to move up this triangle where we want them to be, right? We want them to be the best they can be. We have to consider the basic needs first. Maya, I don't know if you'd like to come off and share experience working in the community.
Sure. So I love this hierarchy needs, and as Dr. Custer said, we could spend this in itself could be a whole training how it relates. But during COVID or during the height of the pandemic, let me say, there was a push to encourage patients, clients, members to take care of their mental health, which I'm certainly an advocate for, but it's really difficult to talk with a single mom about counseling and self-esteem when they're facing eviction. So it's important to take those things into consideration, because as a single mom, if I don't know how I'm feeding my children tonight, I'm not concerned about my mental health. I have to focus on survival.
Thank you for sharing that, Maya.
Mm-hmm.
Okay, the pair of ACEs. This came out of Dr. Dietz from George Washington University, happened to be the Motion Coalition chair, so we like him. But, they talk about the pair of ACEs. So we're familiar with adverse childhood experiences, things that can impact development and growth in the first 18 years. And as an adult, right? But we have to really think about adverse community environments as well. So this is where the system work that we talked about, that justice work, this is where we need to come together and make change so that we can impact all of this. So creating a trauma-informed space. I do a lecture with graduate students on trauma, and they're doing service projects. So these are some questions that I asked them, and these are the ones that I'm going to ask you. So Have you considered the trauma this person has experienced? You could substitute culture with, or even language with trauma. So if you consider the culture of this person, right? Are you creating a safe place for this person to share? Do you have any unconscious or conscious bias to consider, and can you even be unbiased about something? These are for you to think about, right? How does your background, history, worldview impact your ability to serve this person, if at all? Are your actions making others uncomfortable? Are the words you're using respectful and culturally appropriate? And are you actively listening, or are you just listening to talk or just talking, right? So when you're doing service with vulnerable with any population, right, the things that we've talked about are so important. And being able to reflect internally and understand your own, situation and how you create a safe space is important as well. All right, so does anyone have any questions about what we just discussed? Or any comments? Okay, we're going to take a 5-minute break. We're going to finish early today, which is great. If everyone can come back here, let me, 1 second. Okay, so we're going to go ahead and get started with our part 2, which is strategies to overcome vaccine hesitancy. So as you may or may not know, we've been, this grant was started in 2021. And so, we were right in the height of COVID. We are getting to a point now where people are less resistant to getting vaccinated, and we understand that, but we are going to talk about the importance of the vaccination. So vaccine hesitancy is a real global problem. It's defined as a delay in the acceptance or refusal of vaccines despite being available. And some of the reasons why there is hesitancy in the first place, of course, things that we've already talked about, like the inequities and inequalities in healthcare, socioeconomic, lack of effective public health messaging, we talked about that. Certainly unethical research in the past with different groups, as well as structural racism. So, we're familiar with the research of the past that was unethical, that caused huge sense of mistrust, as it should have, in the medical system, right? Social disadvantages, social determinants of health, the growing spread of disinformation and conspiracy theories, barriers to access, not so much in the United States. We have plenty of vaccine here, but in other countries, barriers to access is definitely a cause. So I'm not going to spend too much time, but we're going to review the vaccine. Just so everyone knows, just as a historical record, I suppose, the primary series was a monovalent vaccine, meaning it covered one strain. It covered the original strain. And we all got 1 to 3 doses, depending on the type. There were Pfizer, Moderna, Janssen, which is no longer in the United States, and Novavax. And at the time was recommended for everyone age 6 and older. This vaccine's not recommended now at all. The bivalent booster is now recommended, which is bivalent equals bi equals 2. So this covers the original strain, and it also covers the Omicron subvariant BA4 and 5, and the variants since then, have some protection from this as well. They're all Omicron subvariants. So right now, I did want to quickly just review. We're at a place now where we're not recommending the primary booster or the primary shot anymore. If you're an adult and you've been unvaccinated, or it's been a while, you only received one of the monovalents, you're recommended to receive one bivalent booster vaccine. Okay. Children that are younger, they are recommending using the booster more than once. It depends on the age. So they may get anywhere from 2 to 3 bivalent booster shots, or not, I shouldn't call them bivalent vaccines. Okay. But if they're older than 6 or unvaccinated, they get one of these. So that's the recommendation. Okay. Now, if they're severe immunocompromised, or there's other situations, the boosters are being recommended more frequently, but we're not going to go through that. Okay, so the CDC put out this COVID-19 vaccination field guide, 12 strategies. We're just going to talk about 2. you can look into this after if you like, there's a link. So the first thing we're going to talk about is motivational interviewing, and I'm going to turn it back over to Maya.
Yes. Okay, so motivational interviewing. So motivational interviewing is the guided style of communication that balances good listening with giving advice. So it's designed to increase the patient's motivation and likelihood of health behavioral uptake, and it's based on a respectful and curious way of being with people that facilitates a natural process of change while respecting the patient's autonomy. All right, so the spirit of motivational interviewing. So this table shows on the left side, motivational interviewing, which is a collaboration between the patient and the practitioner, where the joint decision-making is made. The practitioner activates the patient's own motivation and invokes the reasons behind change, and the practitioner honors the patient's autonomy. Now, on the left side, it's authoritative or the physician or the practitioner knows best. So that's a more confrontational, where the practitioner assumes the patient has impaired perception, and the practitioner again knows best. So I like to think about motivational interviewing as the patients or the clients or members, they are the experts in their situation, right? And the practitioners, they are the experts on the medical side. But ultimately, the patient knows what's best for their situation. All right, so OARS. So what OARS is, it's an acronym for open-ended affirmations, summarizing, and reflections. So on the open-ended tab, it's asking and questions that cannot be answered with a yes or no. So those are those open-ended questions. So an example of how to start an open-ended question would be, hello, tell me more about your concerns regarding diabetes, rather than are, do, did, or could statements. So the affirmations tab, it's recognizing and reinforcing the success of the patient and being sincere. That sincerity and that genuine approach does go a long way. When you're not sincere and you're not genuine, it shows. And those are things that do help build a rapport in that relationship with the patient. So on the reflections tab, mirror what the patient is saying. So actively listening and using their own words. And summarizing. So the summary is a really important step. It does let the patient know that you're listening. And then during the summary, if there's any discrepancies in information, that's when it can be cleared up. All right, so motivational strategies to discuss COVID. So start with an open-ended question. A soft start to a controversial topic. Acknowledge the patient's concerns without judging. Empathy reduces the perception that you're approving or disapproving. Avoid criticizing the patient's information source. That information source may be a highly respected community member, it may be a church leader or an elder, and we don't want to disrespect that. That's something that will break down that relationship and that rapport with the patient. All right, so the fourth is show awareness as your status as a messenger, especially with our communities of color. Our representation is very important, and we do want to acknowledge that. And link vaccine acceptance to the patient's hopes and goals. Whenever I think about this point, I think about patients or clients who were saying, you know, I want to get back to spending time with my grandchildren that I love so much. So link that to the vaccine or their acceptance, you know, hey, I know that it's important to you to get back, you know, with that time with your grandchildren. So that's something to consider so that you're at your best, so that you can be healthy for those grandbabies.
Hey, thanks, Maya. We're going to do a quick example. I know I've said this like 8 times already, but motivational interviewing is something that you have to practice. You have to learn, practice, and master. So it's not just something you can just do. We are going to do 2 examples of an interaction of a mom and a doctor in an office. The first example will be based on the traditional approach. Like Maya said, the provider's the expert, they're confrontational, they know the best, right? That kind of situation. The second will be a motivational interviewing approach, and you can see how that works. All right, Mrs. Campbell, it's important to immunize your child. If not, you're putting him in danger. Do you know there's still cases of measles? The disease can be very dangerous. And what about meningitis? It could be fatal, you know. You should update your child's vaccinations as he's already late for the schedule. We could do it now if you want.
Well, I don't see the urgency, and autism is way worse than measles. There are more problems and solutions with this vaccine. Moreover, it's completely unreasonable to give so many vaccines at the same time.
Studies have demonstrated that there's no link between autism and the measles vaccine. The vaccine is safe, I assure you. You should be aware of the information you're getting on the internet. Giving several vaccines at the same time is safe and not associated with more pain. We should update his vaccines now.
Well, I heard something else, and not just from the internet. I do read a lot, and the vaccines are not mandatory, so I can really do whatever I want.
Yes, you're right. It's not mandatory, but you're putting him and other children who cannot receive vaccines in danger. The risk of disease is much higher than the risk of vaccine. If I'm taking the time to speak with you, it's because it's very important.
Yeah, well, that's easy for you to say. Everything is just so quick. But what if my child gets autism? I'm worried about the risk of vaccines, but you don't seem to be worried about my child's health.
Of course I am, and I'm worried about the fact that he could get diseases we can prevent with vaccine.
I don't think that we're understanding each other, so let's just talk about this at another time.
Okay, so in this example, I adopted the role of the expert, used a directive intervention, argumentation and writing reflex, which is the technical words of what we just did. And you can see how the interaction led to an opposition. So let's go through it again with a motivational interviewing approach. Ms. Campbell, what do you think about the advantages of vaccination?
Well, I know that vaccines protect children against several diseases that we don't see anymore. My child received all his first vaccines, but I'm worried about the measles vaccine that it may cause autism. For other vaccines, I have fewer doubts, but for that specific one, I'm still hesitating.
As you said, vaccines have reduced diseases in such an important way that they are now much less frequent. It's why you vaccinated your child when he was a baby. If I understand you correctly, with the exception of measles, other vaccines seem safe to you?
Yes, so I know it's a good thing to prevent those infections, but with the measles vaccine, I'm conflicted. You know, I read a lot of books and articles, and lots of people are worried about the link between the measles vaccine and autism.
So you find it's important to protect your child against disease when the vaccines are safe, but you're worried about what you've heard about autism and the measles vaccine. I see that you've done a lot of research. If you agree, I can give you some more information about that study on autism and measles.
Sure, I want to know exactly what's happening.
In fact, you're right. One study had hypothesized a link between the vaccine and autism, but the study was fake and the author lost his medical license. More than 500 additional studies around the world have demonstrated there's no link between the vaccine and autism. The frequency of autism is the same in vaccinated children as in non-vaccinated children. What do you think?
Well, okay, so I'm not so crazy to be worried about this.
Of course not. You're totally right.
Okay, well, thank you for taking the time to understand my concerns. I think it's a bit more clear now.
Okay, so, we used open-ended questions, reflected what she said, and she's more accepting, right? So these are the differences: using open-ended questions, actively listening, reflecting, and then summarizing. So we're looking to connect with the member or patient and determine their motivations, right? So that's an example of motivational interviewing. Okay, misinformation, disinformation. Who knows the difference between misinformation and disinformation? Anyone? Mr.
So is the disinformation intentional?
Yes, Mr. Montgomery, we can't hear you if you're talking. I apologize. So misinformation is shared, but is incorrect, but the person, it was just an error. It's kind of like patient safety. If you think about an error versus a violation, disinformation is purposefully spread. So let's talk about social media. Social media, this slide is only just to show how much social media we now have in 2022. And so we understand that there's all these different sources of information. So it's no wonder that we all are on different pages about things, right? So just keep that in mind. And like Maya said before, but again, I'm just going to repeat, the best strategy is not to argue against someone's mis or disinformation. You know, don't judge, don't argue. Just use credible sources to demonstrate facts. It's better than trying to do not judge or argue. It's not effective at all, right? Using trusted messengers, like Maya said, you know, local celebrity, faith-based, or neighborhood champions. One thing I wanted to bring up quickly with using credible sources is we typically get a question that says something like, well, what happens if the person doesn't believe the sources are credible? So there's a group of people that don't think the CDC is a credible source, right? So we just have to keep that in mind as well. Again, don't argue or judge. Accurate information. We had in the past, the CDC had a slide with hospitalizations and deaths. At this point, we have cases and deaths that they're showing. So here's just, you know, accurate information. Here's the data, right? So unvaccinated, you're still more likely to catch, I don't think catch is the right word, but to get COVID, right? To test positive for COVID. People that are vaccinated, less likely. When we look at deaths specifically, we can see that people that are unvaccinated are 5.3 times more likely to die, or people that are vaccinated are 5.3 times less likely to die than unvaccinated. So there is, you can see here, this is the unvaccinated, this is the vaccinated, and the booster is the green. If you'd like to see this data, it's available at the CDC. So these are the actual data. All right.
Yeah, so thank you. So this is another interactive slide. So would someone or can someone share a situation where someone refused to get vaccinated because of mis or disinformation? How did you react and was it effective?
Did anyone have any encounters with people not wanting to get vaccinated?
If no one wants to share, I have a little funny story I like to share about this. During the very beginning of the pandemic, my daughter was super convinced that the vaccine would give us some kind of superhuman powers, that we'd all turn into like X-Men and fight crime at night and have the ability to fly or turn into zombies, or that something strange was happening. So my daughter, she is a part of the TikTok generation. So it's difficult as a mom to combat TikTok. So what I did, again, not arguing, because of course, social media, those things do play an important role for her. I didn't argue. What I did, I just shared factual information, and I just let her know, okay, there's no X-Men in our community. I don't know anyone who can fly after taking the vaccine. So again, it's not arguing, it's just sharing factual information. And unfortunately, at times when we're working in the community, no matter what we say, the person is not going to agree. They may have their reasons for not trusting the information, but it's just our responsibility to share the facts.
Thanks, Maya.
Mhm.
Okay, so we are close. We do have some time, so we have a very quick case I'm going to review, and then we'll have a few questions, and then we'll be done. Okay, so this is Miss Eliza. She is a 77-year-old woman diagnosed with long haul COVID after experiencing rapid heart rate, shortness of breath, and fatigue since she was hospitalized with COVID-19. She sits in the doctor's office listening to the instructions and going over the next 3 months worth of treatment. The doctor assumes that she must know what he's talking about since she doesn't ask questions and tells her what she needs to do after a few instructions. What the doctor doesn't know, because she kept this a secret for as long as she can remember, is that Eliza does not know how to read because she dropped out of school when she was 8 to help with her family farm and never went back to learn. She has little medical background and barely knows anything about heart disease. He gives her pamphlets and written instructions that tell her everything she needs to know, but doesn't tell her much about what the papers say. He says to let him know if she has any questions, and she responds with, "Okay, I will." Unfortunately, she can't read the material and is too embarrassed to admit she cannot read the information, which will lead to problems in continuing her health plan properly. Okay, so that's our case. So we have 3 questions if anyone wants to come off for discussion. Did you recognize any red flag behaviors? Anyone want to jump off? So what did we talk about earlier with asking questions?
Mhm.
Yeah, I noticed that she didn't ask questions.
Mr. Montgomery, we can't hear you. So if you're talking, I appreciate you. I just don't know why. So how, how can we know how limited health literacy can impact diagnosis, but more importantly, how could the provider organization been more health literate in this example specifically?
Reviewed the materials.
Absolutely. And ask more open-ended stuff, certainly, right? To gather information.
Are you using TeachBack?
Or using TeachBack. Thanks, Maya. Okay, so that's all good stuff. All right, so we're basically wrapping it up. I'm going to turn it back over to Maya.
Yeah, so some of the key summaries or key takeaways today is that low health literacy is associated with lower health knowledge, poor medication adherence, increased use of ERs for primary care, and increased mortality rates. And all these things, of course, impact the quality of life and our impacts of low health literacy. It's important, again, to use those universal precautions as we discussed. So assume that everyone has low health literacy. Don't assume that a patient understands. Make it plain and easy to understand, and improving individual and community health literacy levels can reduce vaccine hesitation and increase COVID-19 vaccination rates. All right, a final review. It's recommended that all written material be at a 5th and 6th grade reading level. Health literacy strategies can be used to increase the patient's understanding about their health condition, empower them to take an active role in their health. So some of the things, again, are clear communication, TeachBack, using linguistically and culturally appropriate materials, motivational interviewing, and combating misinformation.
Okay, so, oh, that's an old email, but that still works. If you are interested in contacting Maya or myself, our emails and phone numbers in the slides. Before we do this, I just wanted to show there is an additional training from the CDC that's pretty good, health literacy for public health professionals. And here's some of the resources so you can access what we talked about. So we are actually at the end of the series. We'll open it up for any questions if anyone has any. If you'd like to participate in the post-session evaluation, there's a link in the chat box, and there's also the QR code. Now, if you'd like to receive a certificate of completion from Wayne Community College District, you'll see in the post session, it asks for some information, personal information. Wayne County needs that so that they can register you as a continuing education student to award the CEUs in the certificate. So if you are interested, please provide that information. This is being recorded, of course, and I will distribute the recording. I'll send out the slides and the recording probably tomorrow. Okay, so we thank everyone.